So all of you are eager to join for a angle blade plate?
Yes, sir.
Okay, great. So let me have some interaction prior to the discussion. Dr. Gadigone is joining within a minute or two. So who are all doing angle blade plate already? Or there are some reservations in using it?
Good evening, sir.
Good evening, Harjot. Welcome.
Sir, as you know, I have already bought the set, but is still not able to do it due to fear. Can I try it in simple case where I am going for DHS?
सर हरजोत जी तुम सभी में ट्राई करो नो इशू
Absolutely no problem, Harjot. See, it is an implant which requires only one thing, and that is exact placement. Beyond that, there is nothing. So you don't lose bone. It is bone forgiving. It doesn't eat up bone. It gives absolute stability. What more you want in a fracture fixation? The only thing requirement is a exact implant of size and possibly exact placement with biplane imaging is a must. That's all. Beyond that, there is nothing. And what I would recommend is see one procedure live. That takes away all the inhibitions in starting angle blade.
चांडक सर
Oh, yeah, Gadigone sir, please, most welcome.
we'll start in 5 minutes. There is no issue. Or just I will start now.
No, we
Good
can.
evening, sir.
Welcome, Gadigone sir, and welcome everyone. This is going to be a very, very interesting lecture, and Dr. Gadigone has prepared very nicely this lecture. He has extensively used it in unstable fracture neck femur. Though I continue and Dr. Tanna teaches it for basically difficult fractures, difficult unstable fractures, where a prior reduction is must, and in subtrochanteric non-union and non-union distal femur, which are the very standard gold standard indications for angle blade plate use. Specifically, non-union subtrochanteric, which gives everything what you want in a non-union. You want a good stability, you want alignment, you want compression, and you want absolute stability. So all things are provided by angle blade plate, and without taking away the bone substance from the femoral head and neck. You don't have to core out, you don't have to rim. Only thing it requires a exact zig, seating chisel, and you need around 8 hands in the surgery. That is what my experience is. So Gadigone sir,
Yes,
with
sir.
that prior introduction and with that question from Rakesh and suggestion from one or two delegates that they have already used it in a non-union scenario. So please start your lecture.
Am I visible, sir?
You are visible very nicely, and your nice pen drives also we can see. So they are full of knowledge, I suppose, with angle blade plate.
So this is the condylar blade plate, or we can also call it as the angle blade plate. So we'll have some free discussions along with the cases, and Chandak sir is here. We can discuss why I have used it in condylar blade plate. Having done since last 35 years DHS and extensively used last 20 years the PFN also. The condylar blade plate I started using since 1.5 years after this seeing the video of Dr. Tanna sir and his lecture also. I got inspiration from him that why not I can also do a condylar blade plate surgery. So I started as Dr. Tandak sir said in the non-unions and some indication of neglected intertrochanteric fracture. And then I suddenly switched over to the fresh fractures of the unstable variety of intertrochanteric fracture. So my now the whole lectures is around the unstable intertrochanteric fracture. how I fix with the condylar blade. But I am not against those who are doing intramedullary nailing. I am a strong supporter of a intramedullary minimum invasive surgery. But over the years, I have found that there are so many complications of all methods. So why not to try a condylar blade plate? And I probably have done more than now 50 cases. And now I can say confidently that really condylar blade plate works in an unstable trochanteric fracture. So this is a 15 years old literature, no fresh literature. The last paper that you see in a reputed journal, it is in the 2009. And after that, in 2022, it was just an Indian report in some non-index journal that is there, but mostly they are in the reputed journal before 2009. 2009 is the last where there was a comparison between the condylar screw and blade plate, and that's all. So why this has gone into disrepute? It's because of the mostly it is said that the technically it is difficult, and once if the complication occurs, it is a not a forgiving complication of a condylar blade plate, and therefore easy methods are there. And then in the surge of a intramedullary nailing, everything overshadowed, and everybody start all over the world doing a proximal femoral nails. So these are all unstable variety of fractures. A2, 3 with more than 2 intermediate fragments. You can see here more than 2 intermediate fragments, and A3 is a reverse oblique. So this is how in the textbook or in all literature it is written that A2-3 fracture and A3 fracture, that is reverse oblique, they are considered to be a unstable fracture. But with the knowledge of a CT scan, now it is considered that the A2 fracture also they are an unstable variety of a fracture, and therefore if you compare the results of DHS, PFN, they are also much more failures in the A2 type of fracture, whether it's a 2-1, 2-2 or 2-3. Exactly 2-3 is labeled as a most unstable fracture. So what is there in the A2 fracture and why the PFN or DHS fails? It is because that a large banana fragment which is seen posteriorly with the attachment of a iliofemoral ligament, and there is a coronal split may extend from the one trochanter to the second trochanter, and there may be a posteromedial fragment that is the most unstable variety which you see when you have the fracture with a posteromedial fragment. So what happens when you pass a nail? Why it fails in the A2 fracture also, though it is said to be a relatively stable fracture, because there is a translation of the fragment after passing the nail, and it produces a wedge effect, and sometimes you get while passing the screws through the cephalic screw, there may occur an incipient fracture in the lateral wall because very thin wall is remaining here like this, and the same is true with the DHS, and same is true with the PFN also, because we have to pass 8.5 and 6.52 screws. There are 2 holes. Probably they communicate with the intermediate fragment, and therefore the migration of the screw is much more seen in a A2 fracture. Also, with the we are calling it as a more stable fracture. So this is how a distal cortical. Now this is an example. You can see relatively a A2 fracture, 3-part fracture. Distal cortical extension are up to the lesser trochanter. You can see not only there is a coronal split, you can see this is the banana type of a fragment which is seen posterior lying along with the lesser trochanter, and this is A3-3 fracture. It is unstable variety and a very thin wall lateral wall, very thin lateral wall. The anterior extension of the posterior coronal fracture lying to the entry portal of the Haken. So what happened? There is a fragmentation and fracture extending to the greater trochanter, and there is a fragmentation, and if you pass a nail, Here, what happens? The entry point goes lateralized. Whatever you may say that you do it medial to the tip of the trochanter, medial to the tip of the trochanter, even in a practice, when you do it, it is lateralization of the trochanter occurs and there is a wedge effect superiorly. So these are all recognized as a predictor for the post-operative instability after a short or long cephalomedullary nailing. This is in view of a new knowledge which is based on the CT-based classification of a trochanteric fracture. And even they said all A2 fracture which were seen as a more or less a stable fracture, they are all are unstable fracture because of the thin lateral wall, coronal split, posteromedial involvement, and as well as there is a fragmentation of the greater trochanter. So this is how it is, means it is very clear that all A2 fracture now should be categorized into a unstable variety, and what are the complications what we see in the unstable fracture that we can get in the A2 fracture, because A3 fracture we know that it is a most unstable variety of a fracture, reverse obliquity. Therefore, there is no question, but we are not talking much about the A2 type of a fracture. So now this is an example, a intertrochanteric fracture with a banana fragment. You can see here it is extending from the greater trochanter to a lesser trochanter, and there is a posteromedial fragment. Well reduced fracture, valgus reduction, DHS is done, and you can see it is nicely done a derotation screw, and you will find that this is the fracture after 1 month, after 3 months, and after 1 year you find that there is a medial migration. What it has happened? It is because of the incipient microfracture which are seen in the lateral wall that has led to the conversion of this A2 fracture into a A3 fracture, resulted into a medialization. So these are the things which are happens routinely in a A2 type of a fracture. We think that the reduction of a fracture and a stable internal fixation by DHS, but subsequent follow-up, you will find that there is a medialization. So another, why is this medialization? Now you can explain it in a better way. This is a fragment of the small fragment of the banana. This is the larger fragment of a banana, and you can extending from the greater trochanter to the lesser trochanter, and is associated with the posteromedial fragment. A thin wall, coronal split. If you pass it DHS, it will fracture. If you pass even a nail also, it will go through this. So there is only a one aspect of a wedge effect which is seen, that is a separation like a V effect, but nobody has studied that there is an antero-posterior wedging, and therefore this fracture of a banana fracture remains there, and probably if the fracture fixation is stable, it heals, otherwise there is a failure. So you can see this is the fracture, a typical fracture, A3 fracture with a C type of a banana, and you can see from the greater trochanter to a lesser trochanter, posterior fragment, greater trochanter is split. There is nothing like a medial point for entry point. It is a fragmented trochanter, and you will find what has happened. Lateralization of the nail. Though in the C-arm picture it was looking very good, surgeon was very happy, and there is a translation because of the wedge effect by this, because we are not able to locate the medial point because of the fragmentation of the trochanter, and ultimately this has failed into varus collapse and lateral migration. These are the things which happens usually when the large banana fragment posteriorly. So this is how it is, a wedge effect or V effect of the fracture. This is on reduction. This is a negative reduction, lateralization of the point, and you can see how C-arm image reduction and entry point usually it does occur in such a situation. If you leave it like this, it is a day one failure, and these are the issues: varus reduction, medial overlap of the fragment, and the lateralized entry point. These are the things which you see daily when you do a surgery. This is a common mistake, and it is very difficult to find a medial tip of the trochanter when everything is fragmented and it is not aligned with the axis of the femur, though it is looking very good in the AP X-ray and lateral X-ray is deceptive. Mostly it is lying anteriorly, laterally, and posteriorly the fragmented trochanter. And therefore, there is always a possibility of a entry issues. So this is how it is, and exactly you wanted to have our entry point to the middle to the tip of the trochanter or piriformis. It does not occur always even with the experienced hand. So this has happened. Ultimately, what has happened? This is lateralization, placement of the implant through the fracture side, short compression screw, and ultimately loss of reduction, collapse, and cutout of the screw. These are the routine things which you see in all WhatsApp pictures and so many. So, in the current evidence, therefore, IM nail advantages, close technique and load sharing. So this is how it has been advertised that PFN is an panacea over the DHS in all unstable type of a fracture because it's a close technique, it's a load sharing. But this advantage, however, may be compromised in the multi-prong fracture with the porotic head, difficult close reduction, and lack of control over the fixation. This is my view, and probably this is the view should be of everybody, that though it's a close technique, load sharing device giving a good encourage of the fracture per trochanteric, still there are issues in the unstable trochanteric fracture. So this is the
If I can ask you, Dr. Gadigune,
yes, sir.
I am here. If I can ask you, how will you treat that fracture today?
So I am going to explain everything today, sir. This is the beginning of the story now.
Yeah, I have just joined.
Yes, sir. Thank you very much. Thank you very much.
No.
So this is an unstable fracture. So what I wanted to say, sir, that the DHS, PFN is used for unstable fracture, but I was talking about A2 type of fracture where there is a relatively stable fracture. The complications of PFN and DHS are much more because we are not able to understand the pathology behind that fractures. And majority of these fracture, they do stable. After a CT scan, they are mostly a unstable variety of fractures. So now this is an example, an unstable fracture, 4-part fracture, lesser trochanter, greater trochanter, thin wall trochanter. And this is my case. I have done it, frankly, a medial tip of the trochanter, screw length is perfect. Lateral reduction is also perfect. There is nothing. And reduction, entry point placement of the implant. And you can see the angle is also there. Well done surgery, I think so. But what has happened? Bone unable to hold the implant and reverse migration. So when you talk of this thing, you must understand that there is an issue of a bone quality also. So we cannot rely on only implant. We have to think of the bone quality also. So another example, this is a reverse type of a fracture which is going into the trochanteric piriformis fossa, lateral wall, menas, no lateral wall but tracing, and there is a flying anteromedial wall. Ultimately, inadequate 3-point fixation, screws are going through the coronal plane. There is no support on the lateral side, and ultimately abducted floating fragment, varus collapse. Implant unable to hold the fracture. There are only 2 categories. One, that the implant is unable to hold the fracture and the bone is unable to hold the implant. There are 2 things only. So implant unable to hold the fracture, that means there is something wrong in our technique and choice of implant. So now this is often difficult to maintain valgus positive reduction. Nail insertion can potentially lead to fracture propagation and loss of reduction. Complication average 22% with the newer technique, now it has been reduced to 9 to 12%. So it's not an panacea. So since 1932 extramedullary and 1992 intramedullary, techniques and implants continue to be modified, making the older literature less relevant to current practice. Modification implant, but no solution. So if at all intramedullary nailing is so superior and without complication, then why the Europeans and Americans, they are changing the models? It's because a single implant, single design does not give a desired effect in all types of fracture. So evidence, intramedullary and extramedullary, there is no high level evidence. DHS is only contraindicated in reverse oblique fracture. It's a well-known statement and there is no issue about it. So a proximal trochanteric comminution, floating lateral wall, distal trochanteric comminution, thin-walled medullary wide canal, more than 20 mm, a variant of intertrochanteric fracture not well characterized in the existing classification system, and they are termed to be A2-3 type of a fracture, and relatively we call them as a on X-ray a stable fracture, but they are most unstable variety of a fracture. So this is now an example you can see here. A 70-year female, most osteoporotic bone, wide medullary canal, thin lateral wall, everything has gone. So if you do it on reduction, you will find nothing will work. If you DHA, no, you cannot do it because of this screw cannot hold the fracture. If you do a PFN, because the fracture, it will go through the fracture side. Wide medullary canal, you don't have the such a 20 mm nail inside, only you have a highest nail diameter is a 12 to 13 mm. So therefore, there will also be a toggling phenomenon, it will also fail. In such a fracture, nothing works. Only it can work is the but in such fracture, nothing works. Only the condylar blade plate works. So this is how I do it. This is the position on fracture table. You can have a lateral X-ray, more on extension on the lateral side. This is the incision, and slightly I go towards the greater trochanter slightly posteriorly. Why? It's because the floating fragment of a greater trochanter, we have to palpate it properly, identify it, suture it, and then fix it. So after this, we see that there is a coronal split. So this is not seen in the AP X-ray. Lateral X-ray also deceptive, and you will find, and your screws, they go through that hole, and probably it gives insecure fixation. And you can see here, this is how the fragmented trochanter is there. How will you find the tip of the trochanter medial to the tip? We always call it medial to the tip. No, if you pass it through the medial to the tip of the, there is no tip, nothing like it will lateralize, and your fixation of the screws will go through the coronal plate, and this is a day one failure. So what should be done now? So what you should do? Open reduction, clamping of this. So what I will do, I will clamp this coronal plate. So I learned to believe that condylar blade works in such a fracture, and I have seen the condylar blade plate, that video of respected Tanna sir. First, I thought that I can also do it. And then I tried in some of the cases and found that it's not a very difficult procedure. So by Ek Lavya, I have learned from his video, number of times I have seen, I have read the technique, and I started doing this condylar blade plate. And to assure you, and to also confess that I have learned this technique from none other than Tanna sir, because in India, nobody does this surgery. Sporadically, the people do it, but propagation and firm believer to a conviction, Dr. Tanna sir has given me indirect knowledge of a condylar blade plate. So these are the steps of surgery: clamping, then passing guide wire like this near about 4 mm Steinman pin or 3 mm just to stabilize the fragment. Clamping is more important. We have to do an anatomical reduction. That is most important. We must achieve the anatomical reduction. Then there is a guide, and you can see here, this is the guide, 95-degree guide. It is attached to the trochanter. You can see here, and through that we have to pass this chisel. So these are the guides are there, and how I do it, you can see here. So this looks a very stable fracture on X-ray, and when I reduced it in C-arm also, it was looking like a stable fracture. But on exploration, you will find that there is a coronal split, the greater trochanter is fragmented, and the anterior piece is translated, though it was looking very good reduction on C-arm picture. And therefore, what I say that the close reduction in intertrochanteric fracture is an illusion, and therefore it should be nicely reduced, and then the surgery should be done. So then reduce the fracture and clamp it. So
And
that
if you do,
anterior part is the only stable part. We have to align the anterior part and then see the reduction, and we have to stabilize with the pins. And then further surgery should be done.
it is an illusion that if you do the open reduction, the fracture does not heal up. I think it's an illusion. Purely the MIPO people have given this illusion to all of us. I think beautifully Dr. Garigune has done this case, and that open reduction, once you do it, you know very well where the fragments are and how to reduce them. You don't need any theoretical knowledge. All what you need is fix up the fragments back to the positions. And it is what I think so beautifully Garigune has demonstrated. Lovely Garigune.
So next, a very stable fracture. So after this, we have to stabilize with the three. These are the two guide wires. This is one is anterior guide wire, other is a posterior guide wire. So in the AP and lateral picture, we have to find out these are just for marking where our blade will go, where our chisel will go. So that should be anteriorly and posteriorly. It should not be away from the neck, anteriorly or posteriorly. So you get a judgment that where our chisel will go, where our guide will go. So that is very important. So you pass one anterior, one posterior. See in the AP and lateral X-ray, and in the lateral X-ray AP, there is anteriorly and posteriorly within the neck. That is the path for your chisel. So this is not described in the book, but I have modified it like this. So you can see here, this is a 95 guide, and then pass it 2 and see. So sir, it makes your life very easy that our condylar blade plate chisel will not go anterior and hit the anterior cortex or posterior cortex. So you stay with the align with that. So you can see here how it is that you can see. These are the pins, and I am just going along with the pins so that my light becomes busy, and I am completely sure that it is not hitting the anterior or posterior part. So why it is important? So before you go up to the neck, don't hit the femoral head and see in the AP and lateral picture. And then if you want to change, suppose if it is going anteriorly, you can change it posteriorly. If it is going posteriorly, you can change your chisel anteriorly because you are in the neck part. Once it goes into femoral head, it's very difficult to remove the chisel, and therefore I will show you. Now you can see, suppose by mistake, if it goes inside, it's very difficult. It is very difficult to remove from the femoral head. Therefore, any changes, if you want to do it at the neck level and go up to the base of the femoral head. And if it is ensure that it is perfectly, you are in the center of the femoral head or inferior to the femoral head, in lateral view, it is in the center. That is, and then you can hit blindly. So this is most important thing. And then you pass your blade plate. So this is, and it should be another important thing that our plate should be parallel to the lateral cortex of the femoral head. You cannot just change afterwards. Otherwise, there will be translation and malreduction of the fracture. Suppose if you try to bring it Suppose it has gone posteriorly, and if you try to bring it to the center, what will happen? There will be a malrotation at the fracture site. Therefore, we have to align both the things to the lateral cortex of the femur as well as in the femoral leg. So there are a guide which is there. It should be perfectly placed on the lateral surface of the femoral trochanter, and then surgery should be done. So this is how it is. So you can see here, and then
plate hole or the fragmented trochanter.
now there is a facility. You can see one of the hole. You can all trochanteric fragmented. You can suture with the ethibond. No wiring is needed because already
Plate hole
so we can
or the fragmented trochanter.
So if you align the trochanter properly, everything heals in due course of time, and you just see the stability of this, and you can just move it, everything, and you just see the stability of the fixation. So you must test it, this thing, whether it is a stable fixation or not, because the stable fixation will give an uneventual healing, and that is most important. So this is the surgery. So steps of surgery: lateral incision, open reduction, direct or indirect, clamping of the floating fragment, condylar blade plate fixation. This is the 95 guide, which gives aligned to the lateral femoral cortex. You can have a screw placement is also the facility there, so that it does not go here and there. And then you pass chisel to the 95 degree. We have a two instrument. One is a 95, other is a 120, and this is the pusher of the condylar blade plate. This is how it is. This is the two guide wires. They are same in the parallel thing. It is in the center. This is the neck. This is the neck. And the clamp should be kept till you finish the surgery. It should not come in the way of your this condylar blade plate, because it is very important. Otherwise, floating fragment will go here and there because of the impact of the condyle. So suturing of the trochanter by ethibond or a wire. I don't use a wire. I use a ethibond. So this is an example. You can see here, most unstable variety of a fracture treated by a, this is the condylar blade plate, and you can see a perfect anatomical restoration. So what is condylar blade plate? 95 with a dynamic compression hole. It is indicated in fractures in the distal and proximal area of the femur, intertrochanteric vulgization osteotomy, and non-unions of subtrochanteric fracture. Plate have an angle of 95 degree between blade and shaft. There are two holes next to the blade. They accommodate 6.5 mm cancel screw, so that you can go calcar replacement, calcar fixation is there. And these are 4 or 5 or 7 or 8, any holes, number of holes you can get it. They are 4.5 mm. So two screws, at least one screw should go into the calcar, so that it better stabilizes. And nowadays, don't use a calcar screw, because in the press fracture, you may get a fracture of the calcar. So I put it into the inferior part of the this, and this has all been supported by the literature. So rationally of use of condylar blade plate, there is only one negative point, that is it's a load bearing device, whereas intramedullary nails, they are a load sharing device. That is the only. Otherwise, implant is pre-stressed and put on the tension side of the fracture, and thus function as a tension device to address the lateral wall. Anatomical, biological reduction can be done with a open method. This is an example. The plate on the lateral wall seals the lateral fragment. So this is all comminuted fracture, thin wall, and you can see here how beautifully it had buttresses the lateral wall. And this is the screw which must go. Actually, previous literature was saying that it should touch the calcar, but now it is said that the inferior femoral head suffices, because you may get a fracture here in the fresh fracture if you put it into the. But in a non-union cases, it is mandatory that it should go into the calcar to stabilize the proximal fragment. So this is similar to that of DHS and TSP. This is all. So this is all combination of this thing, because what you do is the TSP with the DHS, you do the buttressing of the lateral wall. So same thing can be done because we are pushing just 10 millimeter below the superior part of the neck. And therefore, the whole of the lateral wall is buttressed by the condylar blade plate, and only small part of the trochanter remains. If it is fragmented, you can suture with the condylar blade plate. So it prevents rotation of the proximal femoral head. Compression of the fracture can be achieved. You can use 95, you can use 120 degree. Where to use 120 degree, I will tell. So bone preserving implant, DHS, all these are all bone sacrificing except condylar blade plate and PFNA2, they are bone preserving implant. Technically demanding procedure, as it said in the literature, in every article it is written like this, but it's not a demanding procedure. You can do it very well. The blade should pass approximately 10 centimeter below in the dense part of the femoral head trabeculae, and where the compression and compression. So there is a snugly fitting into the inferior dense trabecular pattern. Therefore, fixation is a robust fixation. Ideal position in the lateral view, it's 2/3, 1/3. It's because if you don't put it 2/3 posteriorly, it may hit the posterior neck. Therefore, the anterior 1/3 and posterior 2/3 like a PFN also. And you can see this is the this is what I was telling, that the calcaire screw, but nowadays I put it like this in oblique screw goes into the inferior quadrant. So these are all for preventing the fracture of the lateral condyle, because it is a lateral proximal trochanter is a precarious. Therefore, drill it first, drill it, create a notch inside by osteotome, and then you can use a chisel. So that is how it is. So slowly, don't use directly chisel. Drill it first by drill bit, or you can use a Steinmann pin. Create 3-4 holes, and then a small slot here. Remove it like this, and then put a this chisel. So this is how it is with chisel sitting subject to the chisel guide by a slight hammer blow. Don't hammer it more, and see whether it goes straight way in the neck, and also see in the lateral picture. So this is how it is going inside, and then chisel it. So reduction must be preserved while doing the condylar blade plate. Once the reduction is lost, then you cannot achieve unless you remove it. So these are all examples. This is a reverse oblique A33 fracture going into the trochanteric fossa. You can see this fracture, and this has been nicely done. It follow-up of a 4 month, no loss of reduction, and everything healed. Trochanter is also, you can see, reconstituted. This is the coronal split. So another example, a bifocal trochanteric fracture, there is nothing. How we can pass a nail through this? And no, there is nothing. You can see lateral picture, fracture neck of the femur. This is how it is, CT scan. I converted into a 3-part to 2-part, fixed it like this. And you can see here how I did a reduction of the neck, condylar blade plate, 120 degree, and trochanter is wired with the, these are all wires, and you can see a anatomical reduction. Ultimately 3 months follow-up, no change in reduction, progressing union, and capacity of this implant to hold this fracture is the most important. It has taken long time to union, but it has sustained. So this is the most important. Rest of the implant, they do not hold the fracture if the union is delayed. This is another fracture, initially treated by osteopath, trochanteric comminution. There is nothing. If you pass a nail, what will happen? It will lateralize. DHS is contraindicated in a such situation. How beautifully open reduction, condylar blade plate 120 degree, and perfect anatomical reduction. greater trochanter is reappeared, and you can see no change in position of reduction, only 3-month follow-up. This is deaf and dumb fellow, and he is very happy. Another example, this is a difficult reduction and maintain a 5-fold fracture. Banana fragment, a large banana fragment with fragmented posteromedial fragment. Trochanter is all this. I did not do anything to this. Did a condylar blade plate. There was a fracture of the lateral wall. And still, you can see the DHS or PFN, there would have been a migration. But in this case, you can see here up to 3 months. Even after the fracture of the lateral wall, the patient is sustained. She is walking without any problem. And I telephoned her
So
last
this is
week.
dual angle blade plate one and the previous one.
What?
This is 120.
This is double
This is
angle blade.
This is 120. This is 120.
So why did you choose that one here?
So you can see here, if I use it 95-degree, probably because the reduction and everything is not good. So that nail 95 goes from here. So already there is a fragmentation of the trochanter. I want to have a good bone contact here. Therefore, I have chosen this entry point. That also given a way, and there is a fracture. And therefore, if you don't find a good trochanter in the upper part, you can switch out to the 120-degree and go through from a good bone quality. And this is 120-degree, it suffices. Now I use a 100-degree condylar blade plate. So put it from the 95 angle, and then I make a 5-degree vulgization. So I will explain you then. So this is another example. Relatively stable fracture, lesser trochanter is not involved. You will see that the mid-intermediate comminuted fragment A22 type of a fracture, osteoporosis, fragmented greater trochanter, and precarious lateral wall. You cannot use a DHS here. If you pass a PFN here because of a fragmented trochanter, what will happen? Lateralization of this will occur, and actually you can see complete restoration of anatomy and healing of this fracture. 6-month follow. You can see identical anatomy is restored, and the patient has a good callus formation. Another example, fragmented trochanter, 8-3 type of a fracture. Lesser trochanter is not addressed, and you did not bother also, but because of a stable fixation, and you can see how the lesser trochanter with this fracture, everything healed, and there is a reformation of the greater trochanter. Another example, this is a large banana fragment with a posteromedial fragment. DHS is contraindicated because of this, and in the coronal split is there, the may occur a lateralization unless you pass through this piriformis fossa. Anatomy restored, additional screw is passed, and the trochanteric wiring is done. And then you can see here, no change in reduction, united in 4 months, and resumed duty as a driver. So such a fractures, when you do a DHS or PFN, I will guarantee you that it is going to fail unless you do a best surgery. And another example, this is how a coronal split. Any nail will go through this fracture side, whatever you do, anterior, linear, or something like that, because there will be a lateralization, fragmentation, and if you pass a 16 mm diameter nail, there will be a wedge effect, though if you pass from the medial tip of the trochanter. So always medial tip of the trochanter is not going to serve purpose in each and every case. Lateralization of the nail does occur. Restoration, perfect anatomical restoration, and you can see how beautifully this fracture is united. 80 years old, gross osteoporosis, thin wall lateral wall, wide medullary canal. Probably Tanna sir will do a prosthetic replacement. I have no objection to it. And you can see here, 6-month follow-up. A lady, village lady, She is able to sit and squat. Perfect anatomy. She had another fracture. And then I did in comparison for this PFNA2 with additional screw. And you can see the quality of reduction of the both condylar blade plate scores over the PFN. Also, you can see here there is a perfect anatomical restoration post-operatively in follow-up X-ray. You can see some translation and extrusion of the condylar, extrusion of the screw. So this fracture has united ultimately, but condylar blade has no change in the fracture side and a perfect anatomical restoration. This is 6 weeks old fracture, 6 weeks old. Callus formation. You can see here, just I did nothing, given a traction and I did a condylar blade plate 120 degree, leaving behind that all this trochanter, and ultimately you can see here, with this also the patient is in 4 months, walking, everything, nothing has happened. And probably now after 1.5 years follow-up, I will get it soon. And you can see which implant will give this type of a function, even in this accumulated 6 weeks old fracture, sitting, spatting in an old man. Another fracture, reverse oblique fracture, better quality bone, gives excellent result. And there is a buttressing of the, you can see here the buttressing of this a floating lateral fragment by the condylar blade plate, floating. Another example, a non-united high subtrochanteric fracture treated by osteopath, and you can see there is a wide gap, osteoporosis. I did a open reduction, fibular graft, choice of implant. You can see if you do a nail, may succeed in this case, but it will require another, because your screws will go through the fracture line in this case. So what will happen? There will be little hole, and while doing a surgery, probably it may fracture. So use a bone shaving implant, 3 weeks follow, fibular graft, and you can see a 1 year follow. Fracture is not visible. Incorporation of the fibular graft, perfect anatomical restoration. And believe he has resumed the duty as a farmer. He is a labor and he is doing a duty nearby my village. So another fracture, intertrochanteric fracture with a subtrochanteric extension, very bad fracture. The fracture going through the piriformis fossa, comminuted subtrochanteric region extension, difficult fracture, difficult execution. Only this fracture can be treated by one implant, that is PFN with a hook plate or a stabilizing lateral plate. That can be done. So I did, and today probably I have shared also. And you can see here in this case, with the condylar blade plate only, you can see here how beautifully this has been restructured. So here it requires a nail plus plate combination, but the purpose is served only by the condylar blade plate 120 degree, perfect anatomical reconstruction, restoration of the length. Another example, adolescent reverse oblique fracture, very rarest fracture. Oblique 16-year-old boy, coronal split, reverse oblique fracture, perfect anatomical restoration. This is recently, I did it 1 month ago, and you can see how beautifully this fracture has been reconstituted. We don't want 16 years old boy. If you have a limp in life with PFN or something like that in translation, because there is a coronal split, it is likely that it may fail. DHS is out of question. What else you can use it? You can use nail and plate combination, but you can use by only a condylar blade plate, use perfect anatomical reduction and lateral buttressing. And you can see here how central placement of the this blade.
Sir?
Yes.
Sir, you are talking about a coronal split in this particular fracture, sir.
Mm.
Sir, so how exactly do we place the guide wires in such a way that it doesn't go through that split? Sir?
Of what guide wire?
Sir, you're told about passing an anterior and posterior guide for.
Where we have to clamp the fracture. First, crux of the surgery is a reduction in AP and lateral view. Perfect reduction.
Okay, sir. Got it, sir. Got it.
So this is how a failure after 3 months at surgery. So even I cannot say that the condylar blade is also a sure shot. Some failures do occur. In this case, this is a reverse oblique fracture, lateral wall has gone. This has also the fracture has medialized. There is it has become like a Houston osteotomy, like a picture. Ultimately, there was a much more varus stress fracture wanted to unite. There is a breakage of the nerve. Breakage of the
Garigone,
Yes, sir.
Garigone.
Yes, sir.
I feel in this one, if you had done a 95, because
It would have
here probably 95 would have been a much
Better.
better option
Yes,
than this 125.
So because it has created something different, because it's a negative, you can see here. So
Yeah.
this was actually, I tried it, but I could not do it, and maybe a mistake was this thing. So failure is the key to success. Each mistake teaches us something. Also, as Tanna sir said, probably 90 would have been a better implant. Failure pattern, mostly it is at the junction of the blade and plate. Why? If the patient fracture takes a very longer period of time, and if there is no adequate calcar fixation and the plate length is short, what happens? The cantilever effect over the load in unstable fracture, and if the metal is not a very strong because of the good company is not there, then probably you will get a fracture this thing. So better company implant is also a very important. And another complication is it is a static implant and may get a superior migration in an osteoporotic bone because the fracture is trying to heal, and because of the overload there may be some cracks in the osteoporotic bone, and you may get a migration of the blade. So these are the 2-3 complications are written, and I have experienced one more complication, and that is the fracture at the tip of the this blade. That is a subcapital type of a fracture. It is not exactly subcapital, it is above that, and that I got, and ultimately I had to replace by a bipolar prosthesis. So dynamic hip screw in comparison with the condylar screw, in elderly patient with unstable intertrochanteric fracture, fixed angle condylar blade plate appears to be a better choice with the lower reduction. This is the only article in a reputed journal in 2009. After that, there is no articles, only a one Indian study, that to a non-indexed journal in clinical study of fixation of unstable trochanteric fracture with 95 angle blade plate. And he said that it works very well, but there is not a comparative study between PFA and condylar blade plate. So having done last 35 years, the surgery by extramedullary and intramedullary implant, I don't say that it is one of the best implant, but I think it gives excellent result in my hand. I have done in this week 2, and tomorrow again I will do a condylar blade plate, because I love to do this surgery, and sir, credit goes to a respected Tanna sir. Thank you, sir. So make one simpler decision today to appreciate the use of condylar blade plate in a difficult trochanteric fracture. And in conclusion, I used it in more than 50 cases with a gratifying result. It's not a difficult surgery. You just do it. You take a bone model first, try to do it on a bone model, and try to see that the some of the patient you can do it with a lower cost and get 2-3 surgeries better and better. You will find that this surgery is most easiest surgery than close reduction and PFN surgery, where reduction is an illusion. Most of the time there is a translation, lateral migration, You get a reverse wedge effect, These are all the things which are now coming up. And probably I will try to explain next time what is the wedge effect, anterior wedge effect, posterior wedge effect, reverse wedge effect, V effect. These are all which nullifies the effect of your compression by doing two screws. And I feel today two screw system is not a good system in the PFL system. Thank you very much, sir. Thank you, sir. Anything you want to add, sir?
Yeah, two things I will talk about.
Yeah.
Those two instruments which you have spoken about. First is the passing the guide wire, which is the most important part, so that you can really do the job in a perfect way. And the second instrument which you have also already shown, that it has to be parallel to the shaft of the femur.
Yes,
Now
sir.
these are the two most important instruments. But if ever still you go wrong, don't worry about it. You're not done any harm to the patient. You can redo the whole thing and it will not damage the bone at all. Like DHS, if you have done the screws, then you have already made the track, so it is going to be difficult. While here it is only a small track which you have made, which is not going to come into the way of revision of the same thing. Within about 10 minutes, you would redo the track and it will not be of any harmful to the patient at all.
Cardiologist have two questions.
Yes, sir.
When you are passing the blade, do you constantly monitor? I have not done it for last almost 15, 20 years. But I used to do it before when it was available. So, do you use image intensifier when you are just crossing that crucial part in the neck?
Only 2 times the image is required. First,
Guide wire.
near about guide wire is okay. 1 inch introduction of your blade or chisel. You have to see whether it is exactly in the center in the lateral view.
Yeah.
That is very important.
Yeah.
When you confirm it, then slide, it will go automatically in there. So any change you want to do it before it is going to the femur.
Crosses the neck part.
Yes.
And in the lateral view, you should be able to see the full blade. If it is oblique, then it's not going to be good enough. So you'll be able to see the full blade. And once you see the full blade, then you know very well that it will not go and it will not cut through the bone at all. And as very rightly Dr. Gadigune mentioned, all these things has to be done earlier, not after entering. You do it earlier before you enter the neck or just inside the neck, and then you will be able to really do the job in the perfect way. I think as a matter of fact, once you start doing it, the technical problem of execution doesn't exist. It is only the reduction part, which beautifully Dr. Gadigune has mentioned about. That is the main thing which you have to look after. Because having done few, now technically it becomes such a simple procedure that you will be able to execute it again and again and again and again. Somehow, all of us, we speakers have been talking about it's a difficult operation, difficult operation, difficult operation. And when we are doing 1,000 difficult operations, this is not the difficult at all, I feel.
And sir, you have to keep the blade part of the condylar blade plate aligned with the shaft all the time. Then if you do it later on, then the reduction will be lost. The plate has to be...
If you use the jig, use the jig, then it will always be aligned. Ne?
Yeah.
So there
One
is
more thing.
There is one more modification now in the jig. You have a screw placement. So what you do, you fix with the screw on the lateral wall so that it doesn't go here and there. So
Exactly.
Exactly.
Gadigone sir, the same question which was asked, if there is a coronal split, then how could you handle that? Because you are having the wedge effect if there is a split in the GT in the lateral plane.
So what I do, I clamp it properly with a good bone wear, not in the fragmented bone. And then what I do, actually it is mostly a posterior coronal split, not an anterior part. Our blade is going from the anterior 1/3 and posterior 2/3.
Yeah.
Therefore, we are going through the good quality of bone. And when you reduce the fracture, it aligns with the fracture shaft. And at all, if it is going floating, you suture with the Thibon or a steel wire.
How do you decide
Which company
how-
is supplying you this?
He has floated his own company.
मैं सस्ते वाला आदमी हूँ, समझ गए क्या?
मैं समझता हूँ. Let us benefit by your जुगाड़.
हरियाणा का जो वीरेंद्र कडियान है,
हाँ.
उसने मेरे को कंपनी बताया जो वो भी यूज करता है.
हाँ.
कंडाइलर ब्लेड प्लेट सेट जो है वो सिर्फ इंस्ट्रूमेंटेशन 33,000 में देता है. मेरे को तो 30,000 में दिया. और ये कंडाइलर ब्लेड प्लेट है दैट हैज कॉस्ट नियर अबाउट 3,500 रुपीस. दैट्स ऑल.
हम तो खरीद लेगा.
Really, I think that Kadian was also one of those who is doing in a large number, like Gadigune. Within a short time, he has done a large number of blade plate, and he has really induced the company to supply at a very cheap price. So I feel in Bombay it is costing quite a lot comparatively, but this one Kadian company, as you said, it is at a क्या प्राइस बोला गाड़ी को ने 3,500 no you said?
और पिटकर यूज फॉर 13,000.
Yeah, that's right.
So Gadigone sir, so Dr. Kadian angle blade plate is available at 850 rupees.
850.
Huh?
850 rupees.
तेरे को दिखाऊंगा 850 में मुझे को.
So they are available. There are multiple Delhi manufacturers now. It is available at 850 sir.
नहीं, Chandak sir, the biggest fear is that good quality condylar blade plate disappeared. It wasn't that we couldn't do it.
Sorry, Negi, it never disappeared. It disappeared from your mind. It is always available.
Yes. Recently I got around 40 plates from AO Synthes. Only thing is you have to place an order and then they deliver. Each is costing around 15,000 now.
Because AO stopped here because there was no demand comparatively. So they couldn't supply it. Once in 3 months, they couldn't supply it.
सर अपने को सिंथेस कंपनी ने स्पॉन्सर करना चाहिए क्योंकि we are promoting.
So Gadigone sir, there are certain interesting questions.
Yes.
So why there is no 135-degree angle blade plate?
It is available 135.
Where it is there. It is very much there.
135.
It is very much there.
Yes.
135.
Yes, it is available.
Yeah, 135. There are 3 angles are available. 135, 95, and 120. 120 is known as Huh?
Sir, I started now.
Yogesh, you want to say something? We are getting a noise from your end.
चांडक सर.
Yeah.
मैंने अभी 110 के 10 मंगाया हूँ. I am going to perform with 110 now. My theory now it is why. Because when you do a 95-degree, you have to go very higher up. And suppose the fracture is not required to go to the higher up to reduce the trochanter. In that case, why not to use 110, go for a minimize the dissection.
Okay.
So that I am using it 110. And there is another second screw, it goes exactly in the lower part, which creates a triangle. So triangular frame gives a better control over the proximal fragment.
Right. Dr. Sangeet wants to ask a question.
संगीत को तो आंसर करना कठिन ही है.
First is everybody in the group must have this as a backup. Only 3 instruments are required and only 2 plates are required. The standard size in a neck required is the length of the angle plate. The one which goes inside the neck is either 65 or 70. And a 3-hole or a 4-hole plate is required. 2 plates and 3 instruments. One is the chisel, second is a plate holder, and third is a punch. Punch, you can use any ordinary one also. So basically 2 implants and 2 instruments is all what you require as a backup for every intertrochanteric fracture, which on table can go wrong. Now, this is about the thing. Why we cannot use 135 in all the intertrochanteric fracture. Now, what will happen is if you use 135 in all, the chances of the no, penetration in the joint is very high because the angle is it will be parallel to the fracture. So the
It's
chances of,
coaxial. Yeah.
so chances of, if it collapses, the plate will go inside the joint. And that is the reason why do we use a 95? Because it is against that. And the most important is at least one screw, which should have not, like what you said, sir, Gadigone sir, if I cannot have a purchase on the calcar, I put it parallel to the, I put it somewhere in the neck. Again, with that combination, the chances of penetration of the plate and the screw are very high. But if you put it in a cortical part in the calcar, that it very rarely occurs. Now, second observation is we hardly see any good amount of callus formation whenever you're using the condylar blade plate. I don't know the reason, because it is a strong implant and it takes longer time for the healing to be seen. But functional activity, the patients, they do all well in about 6 to 8 weeks time and they start walking. And third thing is that some lady had asked a question, what do you do in a condylar if the trochanter is split? But even in a split trochanter, but remember that you're not using the implant to reduce the fracture. It is only to fix the fracture. Reduction has to be done by the standard way, by holding either with a Steinman pin or multiple pins, the shaft and the neck fragments. So even if the trochanter is split, so still you can pass a chisel by holding the split trochanter with a towel clip and then just pass the chisel to end in the inferior part of the head, not in the center.
Sir, but the blade is still going to be going through that coronal split now. So would that not be a problem?
No, see, the entry point is 1 centimeter from the tip of the trochanter. 1 or 1.5 centimeter always.
Right.
If you're using a 95, which is a standard implant.
Okay.
If you're using 120, then things are different.
Okay.
And other thing is, when you are passing the implant in the calcar, the screw in the calcar, you will have to do it like a leg screw, because otherwise the calcar, it will skid. So you make a 4.5 drill first, and then put in a sleeve of 3.2, and through that you pass it and you perforate the calcar. This is the way in which you will be able to see that the screw goes perfectly there in the calcar.
So sir is answering to the query. What happens is, when you are putting the, there is a provision for 2 6.5 screws just below the angle. So whenever you are drilling or aiming at the calcar, the drill bit skids. Am I right, sir? This is
Yes.
Absolutely.
This is the routine.
This is a point which, so how do we avoid the skidding of the drill bit and aim in a good cortical bone in the calcar? So what sir has suggested, either you can put a guide wire and use a cannulated drill and a cannulated screw, or drill with a smaller drill and then go for a larger drill and then pass your screw.
No, Sangeet. What is described by AO is what sir said. That
it is like a first drill, like when we do the leg
4.5.
screw. 4.5 is the first drill.
Lateral
Then you put
cortex
in a
only.
drill sleeve right up to the calcar. So once you have done that, now when you put in a drill through the drill sleeve, it will not sway around. It will go through the calcar only. And as very rightly Sangeet mentioned, the best part of the calcar should be chosen to pass that screw.
And the problem is the holes, they don't allow the angulation of the screw. Worst come worst, if you want to angle it, you can use a long 4.5 cortical screw.
Yeah. Right, very right.
Sangeet,
that screw is always a 4.5.
No, never.
No, AO manual specifically mentions that it's a 4. Sahab used to pass 6.5. We showed him the book. It's a 4.5. That is how it was passed. This is how he described it. It is described in the AO manual. It's a 4.5 cortical screw, biting the cortex, calcar.
Yes.
But normally in the set, we don't have that long screws. which are usually 65, 70, 75.
Now we keep up to 80, 90.
But if you talk of
We have
it,
bought them.
it has the longest cortical screw up to, I think, 46 or 48.
45,
Not
46, yeah.
not
You have to
beyond
have a special screw if at all you want to use 4.5.
Pelvic set screws.
Yes.
Yeah, that's right.
Sangeet,
Sir,
Sangeet,
another
what I do, I pass
Sir,
it.
Sir, you are not audible clearly. Can you speak louder or come closer to the mic?
Sir, what I do, I pass a 4 mm Steinmann pin pointed to perforate the calcar so that here and there I cannot go. So that is how it is. I do it, and then I pass a drill.
Sir, problem is when you hammer that, it
No,
invariably
no
breaks
hammering, no hammering.
or it angles the head neck.
No,
angle.
Sangeet is going to use 4.5 Steinmann pin on a drill.
Drill,
Okay,
not
okay.
on a drill, 4 mm drill, and then can this.
Yeah.
The advantage is it doesn't break the drill bit also.
Yes.
So, Gadegone sir, there are two residual questions for you. One is angle blade plate and a DCS equivalent can be used instead of an angle blade plate? As we are worried about passing the blade, can we put a DCS instead?
DCS is a good implant. It is a surgeon-friendly implant, and you can. It actually function is the same. But what happens? There is a two. Actually, the category of two implant is different. One implant is of a dynamic class. There is some movement at the screw and barrel junction. So therefore, some unstable construct may happen, and therefore, a condylar screw has been given up in intertrochanteric unstable because of the high failure. Whereas a condylar blade plate is an impaction class. So it impacts and bone preserves, and therefore, if the blade goes in the good cortical subchondral bone, it stays there, and therefore the chances of union and staying a implant for union to occur more in a condylar blade plate. But if we find surgery, the better surgery and easy surgery is a condylar blade plate.
Only other.
Gadegone sir, one more thing. Yeah. May I add, sir?
Sorry.
The DCS, you ought to get at least 2 more 4.5 screws below that. Then only you can use it. While condylar blade plate, you can use it even as an standalone without any other screw in the head fragment.
No, sir. No, we have to use at least one screw.
But you will always get one, sir.
While
DCS needs at least 2 more. At least 2 more below that. Biggest screw.
I hope Adarsh Venugopal, you got your answer.
Because the second question is, when you're using a DCS, you have committed once, you cannot change it.
Gaya.
While a blade plate, you can easily change it without any problem, as I mentioned to you.
Yeah.
And very rightly, as Dr. Negi mentioned, DCS, in order to be stable, because it is a tube on a tube which you are pushing it, minimum 2 screws in the proximal fragment has to be there. So the DCS can be used for the upper femur. But IT fracture, it is not a very ideal fracture.
Okay.
Plus, it's a little bulky there at the top of the.
Yeah.
If the patient is thin, blade plate is a sleek implant.
Yeah.
Being a dynamic implant, probably it is not suitable. And that is the reason, Negi has been quoting since years, the article of Kinast, I think it has come in 90s. The failure rate with DCS has been about 20%, 18 to 20%.
Okay. There is a
But
interesting.
Kinast talked about two things. Gadegone sir.
Yes.
He talked about a biological reduction and tensioning of the plate. That every condylar blade plate or a DCS like implant, once it is used for a subtrochanteric extension, you must use a compression device and compress your fracture. Some of the fractures where you used it, you distally use a Muller's compression device and compress the plate. That is what gist of the article was.
Yeah, but that one is because the DC, about the blade plate earlier which came, they didn't come with the DCS with the oblong hole. Now, since they are available with the oblong hole, you will be able to do the same thing by putting us 2 eccentric screws into those oblong hole. Because earlier it came only with a round hole.
Round
So
hole,
the
yeah.
motor device was a must in order to compress.
Now it is available with the dynamic hole.
Exactly, exactly.
And there is an interesting suggestion from Yogesh, who says who all have done a angle blade plate.
I have done, but not done last almost 15, 20 years.
So I think the whole Tanna sir has taught us. I have done, Gadegone sir, Dr. Sangeet has done, you have done. Anyone else from the audience who has done angle blade plate? He wants a opinion poll.
Chandak sir, actually in a polio patient, it's a very good implant because it doesn't occupy much space.
Yes, it
So
is.
I
Very,
used it in polio patients
yes, it is very
with
good.
bad fractures. So,
So all those who have inhibitions for angle blade plate, I think they all would be having a homework. Go back, take a dry bone or a saw bone and try once in angle blade plate. Create a fracture at intertrochanteric level. Just take a angle blade plate. Ask your vendor to get an angle blade plate. If you don't have, we'll post the address of the angle blade plate from Delhi, which is quite cheap. You get one angle blade plate, try it on a model. And once you do it, I think you will find that it is not that difficult to implant. Only thing is a imaging, which is very essential. That's all.
Probably it takes the shortest time.
Yes, that's right.
Less radiation, shortest time.
Yeah. Only thing
Now,
is,
how to decide, sir, whether to use 95 or 120? What are the indicators?
Majority 95.
Majority.
You start with the 95. As your experience goes, you can try any 110, 100, 120. There is no issue. But first try a 95-degree best way, and it is given in the manual also. And how to do it. You can see the Tanna sir's video. You can see now my presentation. And probably tomorrow I am doing it again. So I will post it tomorrow morning, the steps of operation.
Probably after coming back to India, I will post my video onto the group. So you can actually you can download it and you can keep it with you.
Your video is available, I think, sir. I saw it on the.
I think to the best of my knowledge, it is available on YouTube.
It's
On a
available with
YouTube, it is
OrthoTV
available.
YouTube.
Yeah, it's on the YouTube.
Yeah.
It
If
is
you
there.
type Dr. Tanna and Kondala blade plate, it's available, OrthoTV.
Rakesh, to answer your question, which angle to select? For standard use of a non-union of subtrochanteric region is what 95 degree is a must. That is absolutely must. There you can't use anything else. If you want to use 120 degree for intracapsular non-union, 120 degree is ideal because 90 degree doesn't allow you to do a good osteotomy and fix it still. So there either 95 degree or 120 degree is better. So
I think you put it perfectly right, Chandak. 95 degree is the ideal implant for IT fractures and even subtroch fractures. But for a transcervical fracture, it has to be 125. And that 125, do not push it all the way down onto the bone. Keep it slightly outside the bone so that you will not get medialization of the bone, of the femur lower down. While 135 is a substitute for a DHS.
right. And another very
120, sir. 125 is not available. 120.
And 135 is available.
No, 120 is available and 135 is available.
Yeah, 135 is a substitute for a DHS.
another important tip would be always start with at least minimum 2 assistant and 1 trolley assistant. So you need two assistant, 2 orthopedic surgeons or at least trained surgeons are better to do an angle blade plate.
In the early phase at least.
Early phase at least, because one person is holding the blade, the second intelligent person is hammering the tip, the angle blade plate where it is angle. There is a small round depression on which you have to go on hammering. The third person aligns it with the shaft. So these 3 hands are important, and doing osteotomy in conjunction, then you need to manage everything together. So 2 hands, trained hand at least is a good thing.
Sometimes the proximal fragment goes into varus during that maneuver.
If you are not putting your angle, the 95 degree higher enough, The first mistake I did was, for fear that I am going to break, imagine never ever in an angle blade plate the GT flies and is broken. Never ever. It is sufficient bone all around. So you have to go really higher up, exactly as Gadagone sir showed, that you rise very high near the tip of GT, around 10 millimeters below that, and the guide wire is angled inferiorly. If you do this, then varus does not happen.
Then
So
you will
it-
get a good
If-
valgus, and it is mandatory for the healing process.
Standard, sir, if you err so that there is excessive 5-degree valgus.
Yes.
Yeah.
Yes.
I think Dr. Sangeet has put it on the group, the video about which we were talking about. My video which was there, Dr. Sangeet has put it just now, the link there.
Yes. And
Now Dr. Gadigune, if I can ask you now,
Yes, sir.
when do you choose a PFN and when do you choose a blade plate? You see, you are a very high volume surgeon. So is it undersecondary or it is a particular choice you have?
No, I don't have now. Actually, all implants are, I think they are same. Actually, it's execution which matters. So in PFN, still a choice of implant for me. But whenever I don't get a good reduction by closed method, I will straightway switch over to the open method and condylar blade plate. By opening and doing PFN, I don't like it. But today probably I have posted one picture. I have done the hook plate plus femoral nail. In such a situation, the condylar plate is not going to work because it requires a very long. So nail and plate combination was a good. So condylar blade plate, suppose if you want a very long, then probably it's a very lengthy surgery, extensive surgery. It is good for high subtrochanteric fractures and intertrochanteric fracture phase. But literature is very sparse for unstable intertrochanteric phase. It is mostly for the non-unions and for the osteotomy purpose. But I like now. Actually, मुझे प्यार हो गया है condylar blade plate.
Gadigone sir,
Yes,
this sentence you had used for PFN also. So
But
possibly,
Keeps on changing.
possibly you are at such a experienced stage of life where you want to try everything to get the best of that implant,
Yeah.
and you know where to use it and where not to use it. Like in now suprapatellar nailings, you have utilized it to the best of your abilities for getting good reduction in proximal tibia, and then you extend the indication. So
I think unfortunately, Gadigune he cannot try out another women. So he wants to try out all the different surgeries.
नहीं मुझे एक्चुअली कैसा है नई सर्जरी करने में अच्छा लगता है. अभी मैं एक्चुअली हुक प्लेट जो है ना सर आपका आज पूछ किया मैंने आई नेवर डिड इट बिफोर बट व्हेन आई स्टार्टेड डूइंग इट टुडे आई थॉट इट्स नॉट अ वेरी डिफिकल्ट जॉब. सो दिस इज हाउ इट इज.
अरे गाड़ीगुने तेरे लिए क्या डिफिकल्ट है यार, जो हम कर सकते हैं तू तो जरूर कर सकेगा.
Gadigone sir, everybody is interested in knowing one sentence. Good, nicely done PFNA also gives a good result. ये सब लोग सुनने के लिए तैयार हैं.
PFNA 2
No.
एक्चुअली मैं PFNA 2 भी बहुत करता हूँ एक्चुअली इन कॉन्ट्रालैटरल फीमर ट्यूब. लेकिन मेरा आई डोंट नो 2 screw system nowadays I don't like.
Dr. Shiva is very near to Chandrapur now. He would be annoyed by listening to this sentence.
नहीं उनको मैं
नहीं इसीलिए we have not taken Shiva in this group. नहीं तो वो साला बहुत बारी करेगा.
झगड़ा हो जाएगा.
क्योंकि
गाड़ीगुने साहब एक और तन्ना सर एक और चीज है कि he is such a high volume surgeon that you do the same thing again and again and again. You are bound to become more accurate, faster, precise.
किसकी बात करते हैं तू?
गाड़ीगुने साहब he is such a high volume.
Gadigune.
हाँ.
But I admire about Gadigune. He is a very honest surgeon. He shows his failures.
And longest follow.
Failure.
Longest.
And the way he showed failures of PFN, I think it was mind blowing. Absolutely.
Yes.
I wish we could offer him a garland today.
मेरे से ज्यादा चांडक सर करते हैं. मैं आपको बताता हूँ He is the
नहीं,
most
ब्लेड प्लेट तो नहीं करता है अभी अभी इतना ब्लेड प्लेट तो कोई नहीं कर रहा है जितना आपने एक साल में कर लिया
इतना ही
Nobody
फर्क
is doing.
मैं सवेरे सर्जरी करता हूँ, वो रात को करता है बस.
No, but coming to everyone's apprehension in mind that what is the best indication for a angle blade plate in a intertrochanteric fracture, where you would advise to everyone?
Reverse oblique fracture of any variety.
You would recommend a angle blade plate.
Yes, sir.
Step number 1 is good reduction, clamp it, and then put an angle blade plate.
Exactly. Perfect.
I'll put it the other way also. In a younger patient or in a highly demanding, socially demanding patient, I think the blade plate is a safer operation because you don't get a shortening. While in a PFN, you may get about half an inch, 3/4 of an inch shortening.
Okay.
And some limb.
Yeah.
Chandak sir,
Because when I practice in Bombay, in South Bombay, I have to be extraordinarily careful about that. That even if the fracture is united, which we in the meeting, we say, hey, fracture heal up ho gaya. But as you know, in my presentation, those two ladies, two very high society ladies, they were miserable with that fracture which was united, but she had a limp.
Yes, and everyone grumbles about it. When there is a limb, they are not happy. The ultimately patient wants a complete.
there are with the actually PFN, actually the sentence is oversold. I fully agree. It's because there are so many issues with the fragmented trochanter, wedge effect. There
but
is
there are
coronal
two-
split.
There are two main advantages of PFN. It's a closed technique.
Actually, I believe that close technique, I have done thousands of cases, but all PFN surgery do not give the equal result. Only if the reduction is good and bone quality is good. Rest is all nothing. If the reduction is not good, it will fail. If it is the implant is going through the coronal split, it is not holding, and there is no 3-point fixation, it will fail. Therefore, I can say that the PFN is the wonderful surgery if the reduction is perfect and placement implant is perfect through a good quality.
Chandok, if I can ask you.
Yes, sir.
Chandok.
Yeah. Yes, sir.
You said it's a closed surgery. And so the blade plate is an open surgery. Does it make any difference in the healing process or anything?
The problem with open surgery, there are certain setups where complete opening of proximal femur lead to a lot of catastrophic problems, sir. The peripheries where I see the theaters where everyone keeps on coming, entering and going out in the theater. And if those cases get infected, that becomes a problem. Therefore, by default and by exclusion, those surgeons avoid open surgery. Also, many of these at present working DOT people who had very little experience during their training program call some technical guy from the instrument company, and he is the usual assistant to them. And PFN being a ZIG assisted surgery, it becomes very easy for them to execute that. That is what is a reality also as per one of the American papers also. So the American paper said most of the newer generation and current surgeons are using intramedullary implant for this reason, because you are in a different setup, going to different setup, taking the kitty with you or taking the loaner set with you. So these are the realities of practice. I don't know whether I am right or wrong, but this is what my assessment is, sir.
Yeah. The newer generation of postgraduates has not been trained for DHS or any other implant except PFN. They haven't seen it, they haven't used it. Tanna sir, I wanted to ask you that Paul Barbosa, who is one of the designer surgeon for this Synthes, TFN and those things, he used to proclaim that nail is the new lateral wall. Shetty from Hinduja also showed us cases after cases where lateral walls was simply broken and not reconstituted. And his conclusion was that nail is the new lateral wall, and if you reduce it well, anterior and the medial cortex, and place your nail perfectly, it will heal. Any comments on that?
I think Gadigun has shown so many cases, and even Naveen has shown so many cases where everything has been perfectly done. Still, PFN is an unpredictable surgery.
Yes.
Yeah.
Agreed, sir. Yogesh, you wanted to ask some question? Go ahead. Your query is answered.
Unmute yourself.
Muted.
Say,
Unmute yourself.
Yes, sir.
this forum is for
My
interaction.
query is answered, sir.
Answered. Okay. So I
Yes, yes.
request others to please. Otherwise,
So we have to purchase one angle blade plate also with pediatric DHS, adult DHS, PFN, long PFN, and now angle blade plate. So our
13 chips.
And a
inventory.
THR and a bipolar.
परचेस करने की कोई जरूरत नहीं. You get a donor set. No issue.
So
If you have a sufficient volume in the area, the instrument companies are too happy to give you loaner sets and only the implant charge.
Yes. Any other question from anyone? Harjot, you had some question or comment on your reservation for using an angle blade plate?
I think in the audience, as you very rightly said, everybody will have the reservation. I
Yes.
remember everywhere where I have gone,
We have not seen, sir, live surgery.
I think, see, if you see the video which Dr. Sangeet has circulated just now, he has circulated the link of the video. It is the one which I had shown in one of the meetings, and it is there on the YouTube also, which fully describes the surgery and whatever the steps and everything. But I feel that live surgery may not be as informative all the time, because you may not be able to show live surgery with the X-ray. That is what is there in that video. I feel first see the video, you will be able to be, majority of the people have been able to do this, and I'll put it down. All the people who worked with me have been able to do a blade plate.
Yes.
So if the GT is communicated, then entry will be directly onto the neck.
Sorry?
No.
Yeah. If the lateral wall is broken, the
See,
entry will be directly on the neck. That is what he's saying.
So Harjot, when the lateral wall is broken, actually the trochanter is okay. It's lower down where the lateral wall is gone. So the entry is majority of the time quite intact. Rather,
Even if the lateral wall is broken, the trochanter is not in pieces.
yeah. So
It's a very special situation where trochanter is in pieces.
and if you just reduce trochanter first and then take an entry point, it also stabilizes that broken piece also.
And
And occasionally you may need a tension band for such a trochanter.
Yes.
Chandak sir,
Yeah.
passing the guide wire through the fracture site should not be a fear. Somebody messed up a intertroch type situation in a obese 60 plus lady, PFN, and we revised it with a diamond Hooster of all the things. So you are looking at the head and intertroch part of the whole thing, and you just take your guide wire and just show it and place where you want to place it for a 150-degree angle finally.
Yes.
Yeah. And it worked for a revision also.
Sir,
Yeah, go ahead.
sir, at the risk of sounding redundant, like you said, I think most of the newer batches of postgraduate, I don't think I've not seen a single case of an angle blade plate being done, I'll be honest. Like in our center, we regularly do DHS, sir, but we have never seen ABP being done. So if there's any tip you could give to a beginner, because we'd love to try now that we've seen the advantages of this implant. So if there's any beginner tips or pearls you can give us for doing this surgery.
इतना लेक्चर दिया तो कि और क्या चाहिए?
बड़ा और साहब का वीडियो देखो, it's a beautiful
1.5 घंटा का सब भाषण दिया. Only tip I'll give you, madam, is take out the fear and have a confidence in that surgery.
Sure, sir, sure.
So do we do one demo on a sawbone model on this Sunday?
That would be great, sir.
Yes.
So we would organize one.
Good
demo.
suggestion.
I would
Good
organize,
suggestion.
I would organize.
Sir, Chandak sir, you do, sir.
Yeah, I'll organize it. No problem.
Okay.
So I have a
Among all the people, he is the one who has got every accessibility to everything. If you ask me to organize, it's damn difficult for me to organize. Chandak has every accessibility there, so he will do it very beautifully.
Yeah. So Sunday,
Chandak sir,
yeah, go ahead, okay. Yeah.
sir, do you see any change in morphology in fracture pattern in last 30 years? Because
think-
nowadays we are seeing coronal split fractures more of trochanteric region.
पहले भी
Which
होते
were not
थे,
seen
लोग
previously.
समझ- अरे पहले भी होते थे सर, पहले कहाँ सिटी स्कैन था?
CT scan नहीं होता.
Okay.
But Yogesh, to answer
We are
your
getting
question,
aware of it.
yeah, two things have happened. Previously, it was all domestic trauma. Now,
Okay.
even younger patient intertrochantics are communicated. So,
Yes, yes.
violence and the energy of trauma definitely with the
Yes.
high vascular accident has increased. However,
Yes.
this trochanteric comminution used to be there in those days also, where while doing DHS on an X-ray machine, we used to find all these splits and comminution, which required a lot of additional instruments in the form of small mini plates, etc. We somehow used to manage those in the government setups. It was there. So I think this is
And with the two-wheelers, the way they are driving around and all, I think this intensity of the high velocity injuries to the neck has become quite frequent, which, as you said rightly, earlier it used to be only domestic trauma in elderly. That's what we used to see them.
yes. So today I would urge everyone keep one angle, one saw bone ready with them. So I would not just like to demonstrate. We'll execute at every center, every place. So we'll organize a video demo so that it can focus on well. And also you can keep one laptop with either whatever camera you have, so that whoever is doing, we can monitor that and take out all the reservations. And also you can request either Uma Surgicals or Perfect Enterprises to send one angle blade plate. They will be ready to send. We'll make a request to them. Whosoever is interested, they would send at least one angle blade plate to initiate the process.
So where
And
do we
all
get the
these
saw bone,
companies
sir?
are too happy
There is
to
lot of
organize
disturbance.
workshop in your cities.
Yeah.
Ask
they will-
Dr. Chandok to come over and Dr. Gadigonet to come over. They'll be too happy to do that.
But sir, one more query.
Yeah, please go ahead.
Our colleagues will tell to the patient that this age-old surgery is done to you, and this is a 50-year-old surgery. And
Yeah,
if something happens,
your fear is absolutely right. Now, for such instances, and whenever somebody quotes like this, keep papers ready at your phone and just
Okay.
immediately transfer them. So today itself, a patient came who said for a tibia, somebody had used a fracture distal plate, which was very nicely done with very spare screw. So somebody lamented that enough screws have not been used and all holes have not been used. Immediately, I just transferred them one paper, what is actually a flexible fixation, and they were happy. So you can do that very easily, not difficult. So angle.
And only if the failure is there, you'll have to answer that question. If it has succeeded, then you won't have to answer that question.
See,
Sir, this is
we are all
from
very-
Dr. Malish.
Yeah,
Sir,
yeah,
this
please.
is
so there are
Dr.
many
Maleshwar from
opinions.
Andhra Pradesh, sir.
Yeah, go ahead.
I was using DHS and DHS with the TSP and PFN, and I found PFN has got many failure in my series, sir. But DHS and TSP, I got very good results, sir. And I never done the condylar plate. So that's a thing I was requested, and very thankful to you, sir, for this session. And video demo live is better, sir. We feel. Thank you once again, sir.
We'll organize that. I'll put on the group.
I have seen your cases which you have posted, doctor.
Sir,
I have seen your cases which you have posted, so beautifully done.
Yes.
sir,
I
thank you,
think
sir.
these same cases can be easily well done. They are also the indications for the blade plate.
Sir,
What you're doing, but you're doing a wonderful job of that DHS plus this thing with the
TSP.
plate which you're putting it very well. It is, but
Yeah,
my
it is a fixed
strong
TSP.
suggestion. But my strong suggestion is, please
Sir.
show us the final result.
Sure, sir. Sure, sir.
Well, every those 8, 9, 10 cases what you have shown, is on day
Sir.
1.
Sir.
But we want to see on day 3 months.
Sure, sir. Sure, sir.
If you have the patients, what I would strongly request you for our education is, you call the patients, have the x-rays, start the x-rays from the day 1 to day 4 months,
Finally.
fracture united and patient walking about without a limb.
Yeah, some of the cases I posted, sir. 2 or 3 cases. Rest of the things I would want to, yeah, it's,
I
I'll
think
call up them.
my biggest accusation to the PFN people is they always post a day 1 x-ray.
Yeah,
But the day 4 x-ray, as Dr. Gadigune has been talking about, is the one which is most important. You will see the collapse, you will see the virus thing there, you see the shortening in X number of patients, and that is the one which we want to know.
Sir. Thank you, sir. Thank you.
Dr. Satpal, you wanted to say something, I suppose.
Yes, sir.
Please go ahead.
I'm using only angle plate blade plate in non-union fracture neck of femur with bulgus osteotomy only. I've never used this in intertrochanteric fracture. So after this discussion and this very fantastic video, next time I'll try this. I posted 1 or 2 my angle blade plate non-union cases on this group. I think with 1 year follow-up.
Yeah, that's very nice, and I think everyone initially tries to use them.
Sir, any tip for fracture neck of femur in delayed neglected fracture neck of femur or non-union fracture neck of femur? You have any Chandak sir? You have any special tip and tricks for fracture non-union?
Probably you were not there when we took fracture neck of femur. Probably you couldn't attend because everything was discussed so extensively about it.
No, sir, I was there, but due to some internet connection.
So you probably, because
yeah.
Chandak and Gadigune and all of us had given abduction osteotomy, how to do it, where to do it, along with the grafting, fibula, local grafting, everything we have discussed it, I think, in extensive details. And probably you will also have the videos of that because at that time, the immediate videos were not stopped. I don't know whether it is stopped now or we have started getting next day. I have no idea now.
I go through that, sir.
Your request is well taken up. One case will present of a non-union intracapsular next time, so that we can discuss also on that.
Okay, thank you, sir.
So particularly intracapsular non-union and use of angle blade plate is what you wanted.
Yeah, yes, sir.
Along with
so you present the case and we'll discuss it out.
Yeah,
that's a good idea.
Yeah, that will do that. No problem. Any other question or interaction, or otherwise I think the time to close up. Yeah, you wanted to ask Dr. Durgesh, you can connect and yeah, please.
Today I have shared a case of high subproc fracture doing a PFN and send a CM image in the group.
Okay.
I have sent it CM image in the group, sir, for the high subproc fracture, because before that I have never did any condylar blade plate system. So can you comment on that?
So your query is whether we can do angle blade plate for subtrochanteric non-union?
No. I have done today a PFN in that situation.
Okay.
For a high subproc fracture and shared in the group.
Okay.
If you have the X-ray now, you can share just now. Do you have it here?
Yes, sir. But in this one, okay. I'm trying.
Yeah, if you can share, that would be nice. So on the day of class, I think you can all keep this ready.
Yes, sir.
I think we have been telling it again and again that you people present the case. Now, this batch is an enthusiastic batch. If you present the case, I think it will be much better.
This image, can you see, sir?
Yes. Yeah, we are able
Can you show the pre-op?
Okay, sir. This one.
Yes. We can all see that.
Now post-op.
Okay, sir.
Actually, this was a lovely case for angle blade plate.
Yes.
अभी देखो चंदोक भी बोलता है.
Yes, sir. I totally agree. And right from the first TraumaCon and even before that, we have listened to your lectures and we really agree with.
Sir, this is the CM image.
Yes.
Today I
See,
have
the
done.
anterior reduction is not there. And
Uh,
probably the screws are going through the fracture.
The entry is too lateral.
It went to the lateral, sir. I marked in the piriformis fossa only, but it went to the lateral.
Yeah.
Yes, sir, it said today only.
There was lateralization.
Yeah, it's lateralized itself. And the bone was osteoporotic. So now I should do the condylar blade plate in this type of situation.
This was actually a perfect case because osteoporosis also doesn't affect the condylar blade plate. It is the implant of choice here for subtrochanteric non-union.
Okay, sir. So what Asim Negi sir do in this situation? I want to know the.
Dr.
I
Asim,
agree. Condylar blade plate is a better implant, but it's simply not available. I have got the instruments, but I don't have the implant since long time. So obviously it will be a nail plate combo, augmentation plate and a
Cobra plate like
hook plate, some hook plates.
See, I think I have spoken about it on overkill.
And yeah. And
overkill. I think which I feel that if any question on the table, like in this case, the reduction wasn't very good. It wasn't 100%. You have been able to lateralize. In the security, I would have really chosen a hook plate to put it down there in order to really give me the best possible chance of this.
And one more thing, sir. Once you are committed to a nail and an augmentation plate combo, you are opening the fracture, so your reduction automatically becomes better.
Exactly.
Then you are not no longer hooked on to a one-stitch surgery.
What I would strongly suggest is if you have to open up the fracture to get a best reduction, which you don't get it by joystick, don't hesitate. I would entirely agree if you get by joystick and if it is a closed reduction is 100% fine. But if you have any doubt, opening up the fracture in an intertrochanteric fracture does not affect the healing. And the infection rate, as Dr. Chandok was mentioning, I am not sure whether the infection rate in nailing is less than in DHS. I am not sure of that. Because DHS is also, you will have to open it up. Chandok, is it recorded that?
No, not recorded, but as we see from the mofussil areas and which coming from the peripheral centers, it is tremendous. So when they open up,
Or
but
who
I think
closes your wound, Chandok? Odd question.
so. I don't know, but then reference wise, there is no difference.
Yeah, I don't think it is.
I totally agree, sir. Reference wise,
Chandak sir,
yeah.
Chandak sir, I have a question. What is easier to treat, the infection or a cutout?
The cutout is easier to treat. Much.
Because when there is
agree.
infection, there is already a non-union.
Yes, cutout is easier to treat.
No, infection is gone.
So infection you just manage. You can never infection.
Eradicate.
You can just manage.
And infected cutout?
Yeah, you had double trouble.
Okay, friends.
Okay, sir.
Good night, sir.
Right, sir.
Night. कितना 8 बजा उधर कितना बजा?
So here it is 10 p.m. sir.
10:15.
10 p.m. Sorry.
20.
Where are you traveling, sir?
At the moment, I am in Portugal.
Wow.
Oh, fantastic.
I am going out for 2 weeks. This Saturday.
कहाँ जाता है? कहाँ जाता है?
Turkey जा रहा हूँ.
Turkey, lovely.
Yeah.
But I think fortunately with this internet and Wi-Fi everywhere, you can really, wherever you are, you can really access the things so beautifully. Lovely.
Thank you, sir.
Thank you, sir.
Hello, bye everybody.
Bye.
Thank you, sir. Thank you.
Thank you.
Thank you, sir.